Recording in progress.
All right. Well, good evening or good day, depending on what part of the world you're in. Welcome to our webinar. So this is the AO North America Hand webinar on malunions and non-unions of the hand. I want to let everyone know about some upcoming web-based educational material on metacarpal fractures, soft tissue flaps, mangled hand, and then next fall I'll be doing one on the terrible triad. In the fireside chat mode, we have some all-stars of the world of hand surgery. You can see Jesse Jupiter, Hill Hastings, Paul Benhammer, Tom Hunt, Chuck Cassidy, Chai Mudgall, Harry Hoyen, John Capo, who's going to be helping us with tonight's talk, and then Doug Hannell. So really some great offerings monthly on the web. And then we are back to doing courses in person, so it's great to be back in some semblance of normalcy. We have a regional hand course in March in Ann Arbor, the cadaver advanced upper extremity course in June in Las Vegas. Kim Mesera is going to be doing a regional course in Dallas, and then the comprehensive course in Clearwater, Florida in November. So just some things to know about. I want to thank our chair, Marco Rizzo from Mayo Clinic, for the Hand Education Committee. And then I'm the moderator for tonight from U of M. I'm joined tonight by John Capo from Rutgers, Sonu Jain from Ohio State, and Rebecca Saunders, Becky from Curtis Hand Center, one of our experienced therapists from where I trained. All of our disclosures are listed here, and they've all been mitigated, so there's no commercial bias that you should see. For those of you for whom CME is an issue, you will receive a link after and fill out the evaluation, the questionnaire, and that's how you'll claim your CME credit. As many of you who are familiar with AO know, AO is an independent nonprofit surgical educational society dedicated to improving the care of patients with musculoskeletal injuries. We're not talking about how to use specific plates or screws or anything, but they're educational concepts, and the equipment used is just for demonstration purposes, not to say that the things that we show you are the only way to do it. Just a word on Zoom etiquette. All the microphones have been muted and your video cameras turned off. However, we do invite your participation, and you'll do that through the Q&A mode. We'll answer your questions depending on how we're doing time-wise. Those may be direct answers to you, shared with the group, or we might pose them to the presenters. We'll be using the chat box just for our own internal communication behind the scenes. So we like to think about learning objectives. So by the end of this session, we want to be able to evaluate a patient with non-union malunion of the hand beyond physical exam and routine radiographs, determine whether advanced imaging may be indicated, and understand when the surgical care is indicated, and perhaps decide between surgical options. So again, I'm joined by good friends of mine from the AO Hand Education Committee, John Capo, Sonu Jain, and Becky Saunders. There will be time for questions after each of our talks and then at the end. So I'm going to go into my talk, which is first on phalangeal malunions and non-unions. I do want to thank Marco Rizzo, who provided me with a couple cases. So our objectives are to develop a method to critically evaluate failures in phalangeal fractures, be they yours or that you're seeing as a second opinion, employ an algorithm to determine treatment, and then gain knowledge of specific surgical treatments. So just some general principles, and this really applies broadly across the phalanx and the metacarpal. When you're looking at someone's motion and you're looking to see if they overlap, remember that the tips of all the fingers should point to the scaphoid tubercle, as you see here. But look at the other side. These are actually my hands, and I'm just fine. So if someone has limited motion, meaning if they have a boxer's fracture or a phalanx fracture and they can't flex their small finger all the way, it may look like it's malrotated, but it's just because of the limited motion. And again, compare it to the same motion on the other side. So it's just sort of a general principle in any of these that we're talking about. So we'll make this a little bit interactive. So this is a 52-year-old guy who hurt his right thumb. And it was an open injury. However, sensation's intact, and he has got intact flexion and extension function. So, Sonu, what are you thinking here?
Yeah, no, it's a complex injury. It's a combined injury, as I was taught by Dr. Jupiter. These are tough because you have a soft tissue problem here, as well as a fracture that's comminuted. So I think I need to make sure, number one, do I have, what's my soft tissue situation? Do I have coverage for whatever I'm going to fix?
Yeah. Then, so you're able to in the ER debride it and then loosely close everything. So so then what are you thinking about in terms of management of this fracture?
I want to take care of this pretty quickly. It's an open fracture, and I know hand fractures that are open are different than long bone fractures of the lower extremity, but I probably want to take care of this sooner than later, probably the next day or so.
Okay, and are you a pinner or are you a ORIFer for something like this?
You know, I would try to pin it first, ideally, because I would like to create less soft tissue injury, left periostal stripping that I would probably get by trying to fixate this with a rigid fixation. So I wouldn't rule out plating, but I would try pinning first if I can.
All right. So you did it. And so you got pins in, and as you can see, a couple of crossed K wires and then an axial pin. And things look pretty well lined up. So if you do this or something like this, are you someone that if you have pins in, you put them in a cast, or do you try to get them out and get them moving the joints that they can move? Meaning you leave them as CMC and as MP free, get them moving at those joints.
Yeah, I'm the latter. I like to actually put splints and have the pins visible. Now, are these are all buried, right?
They're buried. Yeah.
Yeah, I think just because I want to see where they are. I've seen too many pin tracked or pin infections sometimes that, the cast covers. So I think having that visibility is good. And I think you'll have enough stability with it. As long as you have a compliant patient, I think that's okay. And I'd probably start moving because the MP joint's pretty much open. It's not going, transversing the joint. If I can gently move that, I probably would, but I'd probably give it at least a few weeks. So I'd probably let this set for about, 2-3 weeks to start moving that MP joint, and probably longer.
So you did that, and one of the pins got soupy and had to come out at some point, but now we're 3 months out and still have some pins in, and the fracture, is that convincing you that it's healed?
No, I don't really see much callus there. I could maybe, trick myself into thinking I may see it on that lateral view, but I don't really see much going on there.
Yeah, it's a little bit disheartening, but as you said, this is an open injury and compromised soft tissue envelope. So he is non-tender over his proximal phalanx. So, maybe you get confidence and you pull out the pins and then you look at it, and now he's 3 months following hardware removal, and he's got gross motion at that condyle and is uncomfortable.
Yeah. No, that's...
So you let him go for a little while. So now he's 6 months out from his original injury. and you and he are looking at this X-ray.
Yeah. So I worry about that radial condyle being non-united. I think it looks like.
So are we going to revise this? Are we going to shoot for ORIF and restore normal anatomy? Are you thinking about just giving up and doing an IP fusion?
So this is a conversation I'd have with the patient. I want to know what the patient's expectation is, what their willingness is to do with further surgery. I think an IP fusion is something that is not unreasonable. It's actually more predictable. If somebody wanted to be one and done, that's probably the way to go. But if he wanted to have motion and give it a shot, and he's willing to put the effort and do the therapy and et cetera, I think, trying to revise this and putting bone graft there would be the way to go.
Yeah. So you do it, and you got this plate screw construct. You've got that condyle back up. And again, you talked about early range of motion. So certainly with this, you'd be able to get him moving at his IP joint and MP joint. And now 4 months out, and he's healed. So again, 10 months out, but as you said, you engage the patient, and he wanted to keep his motion. So there you go. And a happy ending.
Jeff, how did that heal? That's amazing.
Yeah. Slowly.
Go back one. How did that heal?
Yeah.
Happy ending.
Happy ending. Just a cautionary tale. Don't Google happy ending. And look for items to have pictures of.
Jeff, I was going to ask you, do you use bone stimulators and these small fractures, these small?
I have not. It's an interesting question, and there's not science behind it. I have not. I know my colleagues that do. These are long bones technically, but I know when there's diaphyseal fractures of the especially in the tibia, there is a role for it. I have not. So this is a similar injury, and just in the interest of time, we'll run through this. So this is a middle-aged woman who had a gardening injury to her right middle finger, small laceration. So unlike the one that I gave Sonu, this one is basically a closed injury. Again, sensory and vascular intact, and given the amount of displacement, sought some internal fixation. So you see a reasonable pin construct. So, then again, the question is, do you try to get them moving? I've never had a whole lot of luck with getting people moving at the PIP joint where the pins go in the collateral recesses like that. So you can try to move them, but they don't seem to move that much. And then here she is at 2 weeks. Here she is at 6 weeks. No pain, so we can pull the pins. And then unfortunately at 3 months, when you go into the room, she doesn't have a smiling face that she usually has. And she's got discomfort and motion at the fracture site. So options are wait it out or revise it. Some imaging can help us, and I'll advocate in these cases for use of a CT scan. So it's hard when you're looking at select images from a CT scan. So that's her DIP joint, and unfortunately, that lucency is her fracture, which is a non-union. So again, revision with bone graft, in this case, a locking plate. And that allows it to heal. So, John, so this is a 62-year-old guy, retired guy who injured his ring finger. And he's got this proximal phalanx fracture. He's a smoker. Oh, John, I'll just run through this. So, options in this case, we want to get a closed reduction. Unfortunately, the closed reduction has a modest attempt at flexion. His index finger is flexed, but unfortunately, his ulnar 3 fingers are straight. So, what they thought they were doing didn't match what they were actually accomplishing. So, John, in this situation, is there a role for re-reduction in your office, or What do you think?
No, it's inadequate. It's not going to hold because it's that short oblique and it's bouncing around. So, and you're going to mobilize, get everything else stiff. So I think you need to take this to the operating room.
So is this a pinner or a plater?
It's kind of, like most cases with these, Jeff, is it's a sequential, progression. So let's close reduce it and try to pin it. And, try that for a little while and that should work. The canal's a little tight there, but give it 15 minutes. And if it doesn't work, then you got to open it. Don't try it for an hour and a half and burn all your energy.
All right. So what do you think of this plate and screw construct?
I think it's, it's stable. And you have your screws are good. You got to watch your screws or whoever's screws are a little long on the boulder side.
Yep.
Yeah.
So that's what Dr. Capo's looking at right there.
Yeah. And then the question is, how do you get there? If you split the extensor tendon, which you probably have to do, you can go on either side, but it's a little hard. They always get an extensor lag.
Yep.
And I don't know why. Some of them don't, but most of them do, even if I repair it and rehab them. So I think the reduction is good, and I think it should heal. But then
I like these little plates. Some may look at this and say it's sort of inadequate. We actually did a biomechanical study on a sawbones on a metacarpal model, but actually found that these smaller, thinner plates are actually more rigid, these 3D plates, than the two-dimensional or compression type plates. They have the advantage of being less bulky as it comes to the tendons. So this is sort of an artist's conception of a compression plate, and this is these 3D plates. And it's this thickness here from the top here all the way to the base that gives you that rigidity. Because remember, the strength is based on the height cubed. So the more of this curve that you have, the stronger it is. But unfortunately, despite that, and despite this biomechanics paper to that effect, this fell apart. So now, John, you got this guy that you've opened up and fixed this fracture, looked pretty reasonable. Now, what do you want to do?
Yeah, I think he probably was moving too and fatigued that, but I think you have to do something different, right? And I wouldn't put, give the bone something different. So you take it all out, see what the defect is. And, the dorsal plate failed. So I'd probably put a lateral plate on, to get more, different screw trajectory. Yeah. And then assess whether a bone graft is needed. You can shorten them a little bit.
Yeah.
But I think you can get, a lateral plate and get a lot of screws in.
So bone graft, yes. And then, so went dorsal, but what would you say is inherently different about this plate than that other plate that we selected first?
Well, it's much more robust, right?
Yeah. So this is a pretty stout plate. The other thing is you do have a little bit of limited real estate here. So the construct gives you a nice tight cluster of screws that you can get there. So this is sort of a neat plate for this. But again, you can sort of anticipate that PIP extensor lag that you're going to get, especially with an even bigger, bulkier plate. But it healed, so it achieved his primary goal. But again, you can sort of see the suggestion of the extensor lag there. And then this is my last case. So this is a 68-year-old guy who injured his finger a couple months ago and saw me as a second opinion. And you look at the radiographs and you say, oh, that looks okay. But he's an active guy, does a lot of office based stuff in his consulting job and notes difficulties typing. So it's his ring finger. What you actually see is some DIP arthritis because he's 68. But there it doesn't look too bad until you start looking at him this way and you see this rotational malunion. So rotational malunion can be difficult to pick up on the x-ray, and that's where physical exam throughout an arc of motion is important. When you're talking about rotational malunions at the phalanx level, you can correct those at the fracture site, which permits angular and rotational correction. And as they queried the famous bank robber Willie Sutton, why do you rob banks? And his response is, go where the money is and go there often. Meaning, if the problem is at the phalanx level, it sort of makes sense to correct it at the phalanx level. The other option is to correct rotational deformities at the metacarpal level, and that way you get completely away from that area, minimize potential for adhesions at the phalanx level. And I've done this a few times. This is Jesse Jupiter taught us this. And basically with this rotational deformity, you make this step cut osteotomy of the metacarpal. I didn't take any pictures of my cases, so I'm using the case from his description. So you make this step cut and you make it long enough that you can put 3 screws across it, as you see here. And then as you remove that section and then close down your osteotomy, you get your rotational correction. So I went in this one at the phalanx level. So here you see my transverse cut at the phalanx level. Get him moving right away. So at 6 weeks, no pain. He loves the position of his ring finger. He's able to type, but the x-ray shows that he's not convincingly healed. So at this point, you know, it's sort of a, do you stay the course or do you worry about it? So since he was comfortable, I let him keep doing what he was doing, which is not stressing it, not strengthening or doing martial arts, but just keep doing typing. And then got a CT at 3 months. And there you see he's convincingly healed. He's got bridging bone across it and he's happy. He's back to his full activities and he's pleased with his decision. So in summary, these are an assessment based on the physical exam, plain films for everyone, and a CT for assessing malunions, non-unions. You know, determine from the patient what the clinical impact is. Not every one of these requires fixation and revision, but some do. And when you do, you want to think about rigid fixation, think about bone grafting, especially in the setting of a non-union, and being able to get going with early motion. And then with osteotomies for these phalangeal malunions, again, you can consider doing it at the phalangeal level or at the metacarpal level. So my references are included. And then we will transition to Sonu's talk. No, I'm sorry, John's talk. Sorry, John's talk. I didn't read my own itinerary. Dr. Capo.
Yes, sir. I'm getting there.
Okay.
Perfect. Your camera is turned off. Just a heads up.
I know. Sorry.
So many things all at once.
No, no problem.
And I was, let's say, I'm trying to share. It's nice to share, right?
That looks great.
Yeah, there you go. Okay. Sorry. Oh, let's start at the beginning. Yeah, just I think those mesh plates are nice, but you can go a little farther out. Like that last one had 2.5 screws in there, and it healed though. So as we say, go long or go home, even in the finger. Good. All right, I'm on. I'm good.
Looks great.
Great. Okay. So PIP fractures, these are a problem, right? And there's no one way to do this. So there we go. No, there's no gold standard. This is a problem. When it subluxates dorsally, that's a problem, right? And all this comminution here makes it happen, but it's not important, but the joint has to be reduced. So this is an old paper from the Hand Journal. Peter Stern, they looked at, what causes instability. So 25% and less is usually stable. And it's kind of like the acetabulum and the glenoid a little bit. It's usually stable, but, an over 40% is unstable, but it's hard to tell how big that piece is. And oftentimes it's an oblique fracture. All right. So we looked at this in the lab years ago, and it's, the volar plate's a big ligament. The accessory collateral ligaments are there, but they don't really, they do something, but if you take those out, it's still stable. So it's the amount of bone there. So we found, again, similar at 35%, they were all unstable. And you saw, subtle instability at 25%. So these are bad fractures. This is a a volar plate arthroplasty that went bad. And I think that that case does not really work, volar plate arthroplasty. So watch for the V sign. This is actually a picture from a book that says this is okay. So first of all, it's flexed too much. It's 90 degrees. And it's not concentrically reduced. This piece here is not that critical, but it's the dorsal subluxation that's the problem. So this is, we'll get to malunions, but this is a simple case. And like I said before, oftentimes we go to the OR and say, all right, we'll try closed reduction, see what it looks like. If not, we might pin it, extension block pin it. If not, we might open it. If not, if that doesn't work, we might have to, graft it. So this is reduced. The volar piece is off, but the cup is concentric. So that heals with a little irregularity on the volar side, but as long as that dorsal articular surface is intact, you're in good shape. So when it starts to pull dorsally and hinge, that's the problem. So this is a fracture where you see this dorsal migration, and it's 3 weeks out. So I took him to the OR. He's a young guy, and he's a cricket player. We were talking about this. Cricket supposedly is a real man's sport because the ball is hard and there are no gloves, but I've seen a lot of finger injuries. So I took him to the OR, and this would not reduce. If you see on the bottom, I'm trying to flex that down and reduce it, but because it's 3 weeks out, it just won't reduce. So we have to do something else. So I was ready to do a hamate, but we shotgun it, found the pieces, and we're fortunate enough to get everything reduced enough with 3 small screws. And he's got concentric alignment. He's got a little cyst in the head after a couple months because of the impact, I think. But that's an adequate reduction and a reasonable reduction. He's got a little extensor lag. So, all right, so malunions. Now, if you don't do this, it becomes a problem. So this is kind of a straightforward case. He's 7 weeks out. You can see he's hinging. He's got this big piece here, which I thought was the articular surface. I didn't know if it was rotated, so I was ready to do a hamate, but I took him, and this guy was tough. He was at work, working full-time, and said it hurt a little bit. So we shotgun the joint, and we tip it up, and that piece was actually down the volar side of the finger, and I found that piece and put it back in, and he's concentrically reduced. There's a little step off there, but I think it's because of the cartilage, but he's concentrically reduced, and he did reasonably well. So when you look at these, there's the dorsal subluxation, the dorsal fracture dislocations. There's the volar, which I've seen a couple times, which is different. Usually, the central slip is attached on there. We have to reduce that. Then there's the pilons that are real problematic. So this is a case that's not really a pilon, but it's a malunion. It's 4 months out. And the question is always, how much of that dorsal cortex is still intact? And it looks like he's got some dorsal cortex, but it's all crumbled. And I used a hinged X-fix for him, which is comes in handy at times, but it has to reduce. So this is a bilateral one. They're cumbersome. They're better for the border digits, small finger, index finger. This pin here is the key, is to get that lined up in concentric. And this X-fix, you can lock it, and then you can get them to move by taking out this proximal pin. So I manipulated this volar piece a little bit percutaneously, and it looks like he's reduced. Hardest part of the case was seeing the X-ray. It's very hard to see through these X-fixes, but he looks like he's concentric. And I started moving him, I think, in about 3 weeks. And not perfect, but the cup is splayed out, but the joint is still concentric. You see this lucency, this lysis he's got in the head from flexing through that pin. But he did reasonably well with a good clinical result. So now these are the cases if it's non-reconstructable and it doesn't reduce, you can't pin it, you can't put a hinge on it, you can take an autograft. So this is the hamate that Hill Hastings developed, and I wrote a lot of stuff on it with him when I was a fellow and then following. So he actually tried a radial styloid first, and it dissolved for some reason. So for some reason, the hamate works. And this is looking at the hamate end on. Here's the hook, and you can see it's got this central ridge in the bicondylar facets similar to P2, basic P2, but it's a lot bigger, so you can take less than half of it, and you can get up to half a P2, and you roll it volarly. So we looked at the size, and basically you don't have to take you if you take the radius of curvature is similar of the hamate, but it's actually flatter. And in this specimen, it looks about the same, but normally the hamate is much flatter. And so that's why you have to tip it up. So this is an old case. This is one of the index cases that we did way back, and this is one of Hill Hastings' case. And this is a bad problem, right? This is a fusion before the hamate, but the dorsal side is still intact. So we might be able to build this hamate onto this. So, I think we're all familiar with the technique, but it's a problem. I'll give you just a couple tips. So, do a wide Brunner incision, bring the flap up, and then everything between A2 and A4, take the sheath, the flexor sheath up, and your volar plate is here. It's very thick. And then you can put that sheath on top of the hamate if it's intact at the end. And then shotgun it, and you look at these fragments. And this is like the case I fixed. Sometimes you can fix this, and you elevate everything, and you can put small screws in. Now we have 1/0 screws, and you can actually put a wire around it. Peter Weiss talked about putting a wire around it. But if not, you excavate this out, and you want to make a big defect there to accept your graft. So once you decide to fix it or to reconstruct it with the graft, you take out even more. Now your graft is important not to lose that and to take your time with this. It's between the 4th and the 5th base. Put a pin in it so you don't lose it. And you can make a back cut here so you can get your osteotome underneath, and you can take an osteotome from the distal side and then hold it with that wire and take your time. And you can go all the way to the edges of the hamate. You usually can leave a little rim, but take more than you need, and then you can play around with it. So this is the first placement of this where it's tucked in and it looks nice on the metaphysis, but it's too flat. Now the cartilage is actually okay because the hamate cartilage is thicker. So if you look at this clinically, if you look at it, in situ, the cartilage is okay, but you see how there's this subtle V sign. It's going dorsal. So you actually have to tip this hamate down, and it reduces it better. But you want to restore that volar arc, the volar lip of the articular surface, and you might have a lucency here, but you can backgraft that. So take your time, and you can see the cartilaginous surface, the joint surface is nicely aligned. You have the tipping, the volar angulation. 3 screws is nice if you can get it. The volar plate, you can replace it down there. It really doesn't give you the stability. And this is the repair of that original case, which is an excellent result. That would have been a fusion. So it's a nice technique if you need it. So let's go to the other side of the PIP joint malunions. And this is a 12-year-old. This is a case, again, Marco Rizzo is always with us. He shared this case with me. 12-year-old injures his ring finger, and he showed up to Marco's clinic at about 2 months out. He's got deformity, pain, ulnar deviation, and flexion. And this is what he has. And this is a problem, right? This is a problem, especially in a young patient. You can't leave this, and it looks like, the condyle is down, and then the metaphysis has some callus there. And on the lateral, there's a double lucency, so something's going on. So what do you do with this? You don't want to fuse this in a kid. You don't want to leave it. It's going to cause arthrosis. So here's a CT scan showing that depressed condyle. And this is a paper from 2002 looking at fixing these condylar malunions. And there's, not a ton of them. So 6 cases in this paper. Problem with this little piece is it falls apart and it tends to die. So if it's healed to the metaphysis, you can do a long osteotomy and bring the whole thing up and put your screws in. So good results. They all heal, but there's a little extensor lag. And 10-degree extensor lag is not too bad at all. So this is another paper from Jesse's group and the group in Taiwan. 5 cases of PIP malunion, and he did a closing wedge osteotomy by shortening the proximal phalanx rather than doing a lengthening. So that's okay. You can shorten it a little bit and less fixation, a pin and a wire, and his results were reasonable. So in this case, open reduction, internal fixation, realignment, K-wires. So how do you get there? So Marco did between central slip and the lateral bands, and here's your fracture. And it's pretty clear. You can see here's the base of P2, and after chipping away at it, you usually can find the fracture line, but it's really how do you hold that piece? So bring it up, And there's always a defect here. It's a little comminuted. You can see there's a little articular fragmentation, but much improved, good result. Pins and a screw, and the lateral looks nice. Your lucencies are the same. And one screw, and it looks very good, and it's much better, but there's probably a little bit of collapse there. So it reminded me of, again, Hill and I think Charlie Eaton have a paper on PIP for condyle fractures fixation, and they found if you get 2 points of fixation, the fixation is, more stable. So maybe something else would have helped. But again, reasonable result. At least the patient has a shot of a good joint. This is another case of mine where just, similar, but a fracture. This is a condyle that's rotated and unstable fixation. And I got 2 screws. I think luckily I shortened that screw. So this looks okay. But if we go back, that piece is pretty small. So I'm saying, is that, am I going to hold this? Is that enough fixation? So I thought about it for, about a minute. And then if I think that long, I said, well, let's buttress this thing and put a plate on it. So I just worry about that condyle slipping. So sometimes that's helpful to really maintain that condyle so it doesn't collapse. So finally, we looked at malunions. We want to make them right. And usually the joint, you have to fix it, but treat the patient, not the x-ray. This is a case of mine that came to the office, then disappeared, came back at about 2 months out, and he's healed. And it's not great, but his hand is fine. He was happy. I was happy. And we don't mess with that. We can make it worse. We can make him have a non-union. So in summary, malunions are best prevented. Understand the personality of the malunion, examine the patient clinically, and articular malunions usually should be addressed. Thank you very much.
Thanks, John. That was great. I love that Jupiter, that extra articular malunion correction. It's really, you have to explain to the parents, and I say parents because I've always done it in kids, thinking outside the box. And if the joint is congruent but pointed in the wrong direction, you sort of redirect it. I like that. All right, Sonu, you ready?
Yes. Let's see here. Okay, great. Thanks, Jeff. I appreciate you having me here. And for those of you that want to see the Ohio State-Michigan rematch, this is it. Actually, I'm going to be talking about metacarpal malunions and non-unions. So let's see if I can advance this. So 40% of all upper extremity fractures are involving metacarpals. And most commonly, not shockingly, it's the 5th and the 2nd metacarpal. So you can get complications from this. And you can get complications from non-operative management, including malunion and stiffness. You can get complications from operative management, including hardware-related adhesions, tendon rupture, infection, and non-union. Now, you can also get non-union in non-operative management, and you can also get malunion in operative management too. But this is what we typically see. So in non-union of metacarpal fractures, so the definition of the non-union concept are fractures without clinical radiographic evidence of healing at 4 months from initial injury. This is defined by the University of Jupiter and Richard Smith back in 1985. And so ideally, you want to have both clinical and radiographic signs. You don't want to just depend on the x-ray. You don't want to just depend upon pain. You really want to have them both together to really solidify that. And a lot of times non-union is associated with soft tissue injury. So this can include in the setting of nerve injury, infection, including bone loss. And when you have a complex open fracture or a surgical approach that can devascularize the bone, that can create a potential scenario for this non-union. So what are the classifications? Well, so there's 2 types of non-unions that we're going to be talking about. One is the hypertrophic non-union, and we typically see this in those cases where stability is lacking. You don't have the proper immobilization. You may actually have soft tissue interposition at the fracture site, and you can have failed fixation. So the more common type that we see actually is atrophic, which is largely from penetrating injuries resulting in bone loss and or infection. So the treatment for this is for hypertrophic non-unions is to get stable fixation. But for the atrophic non-unions, you really wanted to breed out the bone, use bone graft and have that stable fixation. So this can be done with, wires or plates, but typically it's been found that plate and screw fixation is superior to K-wire fixation. So a new technique, or not new, but a technique that we use for certain areas that's being used more so in the hand is the induced membrane or masculate technique. So this is from the group out of Ortho Carolina. So this is like a two-stage approach to this. And even though this was a traumatic injury, this is very well applicable to a non-union. And so what you want to do in this scenario is to debride at your first stage, like we talked about for like an atrophic non-union, and get your polymethyl methacrylate cement spacer with or without antibiotics. Make sure you have soft tissue stability, and then you're going to have that sit in place for about 4 to 8 weeks. I think Gaston's group did on average about 7 weeks for this. And you at that time go back, you incise the membrane, preserving it, remove your spacer, place your Kensel's bone graft, and then and repair your membrane and fixate your fracture, and then you can get some pretty good results from that. So I think that's something that's being done as an additional way to sort of take care of this. So malunion of metacarpal fractures is the most common complication of metacarpal fractures. So you can get different aspects of the shortening, rotational deformity, and angular deformity. But first, shortening, what happens with this is you get this altered balance of extrinsic and intrinsic systems here. And what happens is you get the shortening, and that leads to extensor lag. So what has been found is that if you get 2 millimeters of shortening, you get about 70 degrees of extensor lag. So your fingers can actually hyperextend at the MP joint about 20 degrees. So if you do the math here, you can probably tolerate about 20 degrees of extensor lag with your shortening, because it'll be offset by the hyperextension. So if you do that math, you can lose about 6 millimeters of length, and then you'll start to get true extensor lag, where the MP joint hyperextension won't compensate for that. So angular deformities can occur both in the sagittal and coronal plane. We typically see this in the sagittal plane, but the coronal plane angular deformities are better tolerated, as can be expected, in the more border digits, because you don't have an adjacent finger on both sides that would impede that. And we see this fracture malunion in the sagittal plane because of and creating an apex dorsal deformity because of the flexion forces on the distal fragment, which cause that. One thing to note is the deep intermetacarpal ligaments actually prevent shortening of your fracture, and they create better stability of the distal fragment of the fracture site. And they do this because of the stability they impart internally, particularly in the internal metacarpals. So you have that deep intermetacarpal ligament on both sides. So malrotation is a little different. You can't compensate that. It cannot be compensated with an adjacent joint. With angular deformities, especially in the sagittal plane, the distal joint can potentially compensate for that. And you can't really get that with the malrotation. So 5 degrees of malrotation can lead to about 1.5 centimeters of digit overlap. And so the way to assess this, and I know it was described earlier, is you kind of make a fist and you monitor the overlap of the digits toward the scaphotubercle, look at that convergence, and any deviation from this is going to give you your assessment of malrotation. So what do we want to do for treatment of these malunions? So for the angular or mixed deformities, you really have to do the osteotomy at the fracture site. If you do it proximal to that, you're going to create two different angular deformities, and it doesn't work well that way. And you can either do an open or closing wedge osteotomy. You can use cross K-wires, plate and screw fixation, or intramedullary screws potentially. For the rotational deformities, you can do an osteotomy at the fracture site, or you can do it proximally at the metastasis. Again, similar methods of fixation. And one thing that was described earlier was the step cup osteotomy, which uses lag screw fixation and creates less adhesions. So you can correct a deformity up to 18 to 20 degrees with this. Of note, some plates are out there that are osteotomy plates, which allow you to get that correction as well to help you with that. One other thought process regarding these osteotomies is to try to make them the metaphyseal junction. And the reason to do this is for a few reasons. One is you get a larger surface area of contact for better bone healing. You have a high ratio of cancellous to cortical bone to, again, promote healing. And you'll have less periostal stripping that you'd probably get with more of the diaphyseal component. So here's a example of closing wedge osteotomy. You can correct both an angular and rotational deformity here by making this cut. You can do the benefit of the closing wedge, you have a single bone junction to heal rather than two. If you have to do an open wedge where you have to put a graft in, you have decreased risk of intrinsic tightness. Obviously, you don't need the graft. And your hand can tolerate a small amount of bone to tendon length discrepancy with shortening it. So you can see you can get pretty decent results from that. So this was mentioned earlier in the previous talk, but I was going to kind of give a little more detail of this modified step cut osteotomy that was described by Jawa and Jupiter. And so you make these hemitransverse cuts about 2.5 centimeters apart, and you connect the dorsal cuts right from, you make your hemicut here, and you connect this, and you leave the volar cortex intact. And then when you reduce the dorsal piece together, it fractures the volar cortex, and then you evaluate to see if you corrected your malrotation, and you can always take a little more if you need to, and then you would fixate that with lag screw fixation. So when do you want to intervene with these problems? So in non-unions, you evaluate the patient to see if they have symptomatic pain, if they have any loss of function, if they have infection. And malunions, you want to be careful here, because you want to, if somebody, if it's, you may want to consider non-op management in mild cases, because if they're doing okay, you always worry about potentially making something worse if your thought of surgery and the outcome associated with it being uncertain. And you also want to be aware of doing this for purely cosmetic reasons. Make sure there's a functional component to that decision making. So I have one case here, which I'm going to show you regarding this patient here who had a previous fixation with an intramedullary headless compression screw for a metacarpal shaft fracture, who failed to heal this, developed this problem you see here. He has pain, he has clicking, likely because of some motion at that fracture site. This is a non-union. So the things we want to think about are, what kind of non-union is this? Well, this is likely, based on the imaging studies and his history, is probably a hypertrophic non-union. And timing, is this really a non-union? Well, 6 months, and he's symptomatically painful, and there's clear fracture site. So it's fitting that category of what a non-union is. So what's the technique for this? So different techniques, as we talked about. In this case, remove the problematic hardware, which was tough. With IM screws, if they fracture within the bone, are really challenging to get out, but was able to get it out. And then use autologous bone graft, and then put a dorsal 2.0 millimeter plate, and he was pretty well healed from this and had no pain, had full function, no malrotation, did well from this. Second, and you can see here the lateral and oblique views of the hand. And the last case I have here is showing you a gentleman here. One of my partners had this case, and he's a patient who had a injury 6 months prior to presentation. You can see here he has angulated metacarpal shaft fractures that have malunited. So again, going back to the algorithm that I talked about earlier, so you want to classify what kind of a malunion is this. This appears to be a angular deformity, doesn't appear to have any rotational component, doesn't have any malrotation. So what are your options for treating this? So in this case, the fracture site was addressed, and using the bone at the callus at the site that was used with bone graft. And you can see two different techniques were used here for fixation to correct the angular deformity, one with an IM screw and one with a dorsal plate. Obviously, the screw was used more for the transverse, and then the plate was used more for the oblique fracture. So take-home messages for taking care of malunions and non-unions of the metacarpals is foremost prevention, right? Try to avoid having them in the first place. And if you are presented with these scenarios, then you want to correlate clinical symptoms with the pathology, radiology, et cetera, because that's going to be important. And then when possible, rigid fixation with early motion is best. Thanks.
Thanks, Sonu. That was great. And it was interesting on that, even on that hypertrophic non-union, the first case that you showed, you, even though you identified it as hypertrophic and said, well, biology is not the problem, you still bone grafted it, because at the end of the day, you don't want the patient to not heal that. So, you know, you sort of have this learned discussion with the trainees that you're working with and the patient saying, you know, this is trying to heal. I just need to provide stability. And then you still add biology just because you want to solve the patient's problem for them. So I'm glad that seems to be a universal. Everyone seems to do that.
Absolutely.
Thanks. And last, so, you know, we as surgeons do this, but then as I tell people that I'm working with in training, you know, we sort of do the surgery with an eye towards how are we going to be getting them moving, and can we move this joint or this joint while we're immobilizing this joint? And you know, the one sort of unique thing about hand surgery is we do the surgery with an eye towards the therapy. And Becky's going to tell us some of the things that, as she looks at these problems, how she sees some of these problems. So thanks, Becky.
Okay. Can you hear me now?
We gotcha.
We just can't see you.
We can't see you.
But we can hear you.
I don't know if that's by choice, by design, or whatever you're comfortable with. Becky, you somehow muted yourself. Becky, are you able to unmute yourself? Or maybe Mackenzie, if you could help her.
Sorry, I didn't have control of the screen. She did, so I couldn't unmute myself.
Okay.
Okay, can you hear me now?
All right, now we can hear you, Becky. All right.
Okay, now.
Perfect. I'm going to give you control again.
Okay, we'll try that again.
Yep.
Oh, the toolbar was there for a second.
Okay, is it there now? It says you're controlling, so you should be able to advance.
I'm hitting video, but it's not coming out. So let me just, you know, if you can't turn on the video, I'll just start talking, okay?
Okay.
All right, so in general, the therapy recommendations we would make are based on the same things for regular fracture management. The things we need to know as therapists are, you know, is the fracture stable? Well, how is it fixed? Were there other concurrent operative procedures? And you have to think about potential dysfunction at uninvolved joints. So a key factor is, you know, appropriate timing for range of motion, and limit the orthosis, immobilize as little as possible. Like, you know, the cases you showed with hand fractures, many of them could be managed with a hand-based orthosis rather than including the wrist. So it's a, you know, balancing act between providing protection while allowing some controlled motion to enhance healing. And many, you know, elegant studies have shown that motion helps to, the stress helps to induce greater tensile strength for tendons as well as bones and ligament. It's not, there we go. So, you know, as with all acute trauma, you want to consider the main things you need to look out for to have a successful outcome is edema control, pain management, adequate protection through the orthosis, and again, immobilizing as little as possible. So then, based on the stability of the fracture, we'll start with active or active assistive range of motion, progressing to passive range of motion, and then to ADL assessment and training. And it's really important to start incorporating the hand in, light functional use early on to promote to promote motion as well as reintegration of the hand. And I'm going to show a slide that shows a study about the changes in the somatosensory cortex that are rapidly induced with immobilization. So, at some point we'll do a sensory evaluation, and one of the common complications, especially with the more distal fractures, are hypersensitivity. And so you want to be aware of that and start desensitization techniques as soon as possible. So this is a study I mentioned, and it was done for in relation to stroke therapy, but it was pretty amazing. They immobilized limbs for 14 days and then looked at the changes through MRI. And there was very rapid reorganization of the somatosensory and motor deprivation. So I think we've all seen it clinically where, some people get very dissociated from their hand very quickly. Doesn't always depend on age. So it's really important to get things, another great argument for early motion. This was a great study that looked at the different types of systems to reduce, or ways to reduce edema through active motion. And so it was done by Angus McGrother and others. And they found 3 different venous pumping systems in the hand. The deep system was activated by isometric intrinsic muscle contractions or resisted adduction. And then the superficial and dorsal systems were activated the most by external compression. So using these techniques together will achieve the greatest venous return, especially if you have them doing active fist formation, and I try to have them do active fist formation in elevation. So now the toolbar popped up. One of the techniques that I really like to use for reducing edema and ecchymosis is kinesiotaping. And, this wasn't a fracture patient, and I'll have to get some pictures of fracture patients with it. But this patient had a redo of MP arthroplasties for her index and middle, as well as extensor tendon centralization and PIP capsulectomy and tenolysis. And that was her at about 10 days. And I used kinesiotape, being careful not to get it to stick to the stitches. And then this is her hand, like it was 4 days later. It's pretty dramatic at how quickly it resolves it. So I try to encourage patients to try that. Not everybody likes the idea of it, but it works really well. So Dr. Brand noted that there's no other place in the human body where the ratio of tendon to bone is as unfavorable as it is over the proximal phalanx. And I love this picture because it shows you all the different orientation of the fibers, the extensor mechanism, and why it's really critical to get things moving as soon as you can so that you don't get adherence and have to, have a secondary procedure. So that area too, the proximal phalanx, there's a lot going on in the flexor system, and that's why it's so important to get things moving early in a controlled manner. And I kind of cringed the other day. I was in clinic with a fellow, and he was talking about proximal phalanxes and fractures and said, you just like to immobilize them for 4 weeks. So the reason it made me cringe is I'm a big fan of Roz Evans' early short arc motion technique, which was originally developed to look at the concept of doing a small excursion to create that 3 to 5 millimeters of glide. And it was done for both, it was done primarily for central slip repairs, but it was well controlled. And both the immobilization group, which used the standard immobilization for 6 weeks, versus the short arc motion protocol, they were well matched as far as complex injuries, which meant they included fractures as well. So you can see there's a very significant difference of PIP motion at 6 weeks, and they also had significant better motion at discharge and also a shorter length of time to discharge. And Roz Evans original study was published in 1994, and then Dr. McAuliffe did a really nice, much shorter review article in January of 2011. So I'd recommend, if you're not familiar with it and you want the Cliff Notes version, to read Dr. McAuliffe's. And if you want to know all the science behind it, read Raz's original. So what we need to know as therapists, if you want us to use this technique when it's a zone 3 extensor or zone 2 flexor injury, well, let's stick to extensors. If you want us to use it for a zone 3 extensor injury with a fracture, then we need to know too if there's a lateral band that has been repaired, because if the lateral band is repaired, then the excursion in the template splints is limited, and they only do 20 to 30 degrees of DIP flexion if there's a lateral band repair. If it's just a central slip injury, proximal phalanx, they could do full, up to their pain tolerance as far as DIP motion goes. So complications include PIP flexion contractures, and this can be a big problem. How we treat it depends on the degree of contracture. It might be something, if they're over 40 or greater, then I would try serial casting first to restore as much extension as you can. And then, you have to remember about the close proximity to those tendons on either side. So early motion is a key to preventing these complications. With the extensor tendon adherence over the metacarpals, this can be, there can be frequently be complex injuries require a lot of wound care and secondary intention, and then they're going to have extensor tendon adherence. So this can be treated with isolated extensor tendon exercises, scar massage, functional electrical stimulation, and other modalities, but the relative motion orthosis can be used to support the MP if there's an MP extension lag while allowing range of motion. And then it's also a great split if the extension lag is at the PIP, then in this, can you see my mouse?
Yes.
Okay, so this picture here, this would be a relative motion flexion orthosis, and that would be good to treat a PIP flexion contracture or lag. And then advance to another slide that shows you, this is a relative motion extension orthosis. So it supports the MP at neutral and the other digits are slightly flexed. And so it can be used for sagittal band repairs or as treatment for complications like extensor lags after a metacarpal fracture. So it has it was originally developed by Wendell Merritt and his group of therapists, and has been, highly advocated by Dr. Lawton and others. And it's a very useful little splint for a lot of different problems. So this was a great article by Dr. Merritt and one of those therapists, and he really uses relative motion splinting for acute boutonnieres, chronic boutonnieres. He's much more confident doing early repairs of central slip injuries with just this. But when you have adherence, it's a great tool to use to help decrease the problem without having to have surgery. For complications of distal phalanx fractures, those include numbness, hypersensitivity or tenderness. Cold intolerance can be a big problem, and limited DIP motion. Nail abnormalities we can't really do much about in therapy, but we just encourage them to, have some faith, give it a little time, and, things can look better with time. So the case that, Jeff, that you showed with the P2, after you pulled the pins, developed a non-union. And, I thought of, when the pins are pulled, P2 have a higher incidence of non-union. You can make a little like a mini Sarmento splint to give it some compression and still let them move. So that would be something that I would try with a P2 fracture.
Yeah, sort of like that short arc little splint that you showed. I like those.
So when all else therapy fails and you have to do a secondary intervention, it can be tenolysis or a combined tenolysis and capsulectomy. But preoperatively, you want to maximize their passive range of motion and minimize edema and scar adherence. And then it's really important, patient selection is really key. If they're not going to invest the time after tenolysis, and if their compliance with trying therapy has been lacking, they need to have a serious talk about what they can expect. Because I've had many patients tell me that this is more painful than the original procedure. So you need to, patient selection is critical, and they have to buy into, what's expected of them after surgery. So we want to, again, focus on edema management, various ways to do that, and also especially pain management, which can be, controlling edema is a big factor in pain management. So generally, if it's a dorsal block split after a flexor tenolysis or a volar split for an extensor tenolysis, and get them moving, sometimes they don't need much splint support. It all depends on how the tenolysis goes and what the findings are at surgery, but you want to get them in an appropriate orthosis and get them moving early. So with extensor tenolysis, this was a case where this patient had a skiving injury over the dorsum of P1. And especially with extensor tenolysis, if they've had a prolonged flexion contracture, you really have to monitor closely how their extension is being maintained while they work on improving flexion. So these patients might require protective splinting for longer periods, and the extensor mechanism has been stretched out, so they need a little more protection and close monitoring. So in general, with those patients, they start strengthening the extensors first and then progress to grip strengthening as they're able to maintain their extension. So outcomes assessments are really important, and this is the standard developed by the American Society for Surgery of the Hand of what a good functional outcome is. You can also use the DASH, the quick DASH, and all these other tests to look at their function. So in summary, with all these injuries, whether it's acute or having to have a secondary surgery, the patient's psychosocial needs need to be addressed, especially hand trauma. It's very stressful to patients, and really fortunate to work here. In the past few years, we don't have counseling on hand, but that was something that Dr. Curtis set up, and we had a social worker that sometimes, she just did. I called her St. Anne of the Hand Center. She did great work with these patients and helped them get through difficult times. So communication is essential with all the team members. And if you don't have an on-site therapist or social worker who does counseling, you need to have a good referral source. And then, we therapists have to have a knowledge of normal and pathologic healing of different tissues. And reconstruction is essentially a salvage procedure to restore hand function, and our therapeutic intervention should focus on restoring maximum function and not, promise them that's going to be, never promise them it's going to be perfect again. And some patients have a harder time than others accepting that. I've heard it so many times. I'm a fast healer. Well, tendons and bones, nerves, they all have their own rate of healing. So there's no specific protocols for therapeutic management of the mutilated hand, and each component of the injury requires consideration during evaluation and treatment planning, and it's definitely a team approach. So there's Dr. Curtis operating and teaching.
Excellent. Well, thanks, Becky.
You're
so
welcome.
One of the questions that came up, and you showed that dramatic case, and that generated a question of how does kinesiotape work?
Oh, well, you have to move for it to be able to work. So it lifts the skin and it provides a little micro massage. So it helps with lymphatic drainage, and it can stay on for, 5 to 7 days. Patients can get it wet. And then it just, dries really quickly. And, after you have it on for a while, you don't even know it's there. It's pretty amazing stuff.
So is it that with motion, it accelerates edema management more so than just the motion itself?
Definitely.
In other words, it's adding something. It's not allowing you to move more. It's taking that motion that you have and it's improving the amount of edema resolution.
Yes, because it stimulates the lymphatics. So when you put it on, you put it on a little bit of stretch, and then when they move,
oh, I see. Okay.
It stimulates the skin. It lifts it, and just creates a little micro massage too. So it's very, very, I'm just amazed at how quickly it resolved the ecchymosis in that case. And it's hard something to measure, but there are being more studies done with kinesiotaping. It can be used for a lot of different things. It can be used to inhibit muscles or, enhance contraction or provide stability. I've used it sometimes, laterally for collateral ligament injuries to the PIP, and it helps to, decrease their pain, and definitely is my favorite uses for edema reduction.
Excellent. All right. Well, thank you, everyone. And nice job, everyone combined, staying on time. So thanks, John and Sonu and Becky. Thanks, everyone from AO, Mackenzie, Jenny, Abby, and April. And there's Ron. So anyway, thank you, everyone.
Thank you.
Have a good night.
Thanks, Jeff. Great session. Take care.